here today, the 14th day of September 2021, for the 355th inaugural lecture of this university. The lecture today will be delivered by Professor Omolola Oladunni Irinoye. Professor Omolola Oladunni Irinoye was born on the 15th of July 1956 into the family of Pa Samuel Bolarinde and Madam Elizabeth Irinoye. She started her primary school education at Baptist Primary School, Igana, Oyo State. She had her secondary education at Imesile High School, Imesile. She had her nursing training at University College Hospital between 1977 and 1980. She then proceeded to the prestigious Premier University of Ibadan in 1981, where she had her first degree in nursing in 1984. She had masters in nursing from Obafemi Awolowo University in 1991 and masters in women development and administration from University of New York in 1988. She then proceeded to University of KwaZulu-Natal, Durban in South Africa, where she bagged a Doctor of Philosophy in nursing in the year 2005. Professor Omolola Oladunni Irinoye is a recipient of several awards and scholarships. Notable among these are the award for Outstanding Piece of Master's Work given by the Center for Women's Studies, University of York, UK in 1999. Carnegie Fellowship Award for Female Academic Staff of the Center for Gender and Social Policy Studies, Obafemi Awolowo University, Ife in 2004. National Trainer in Distance Learning, awarded by the British Council in conjunction with the National Universities Commission in 2011, and International Scholar Travel Award by the Office of Global Health, School of Nursing, University of Maryland, Baltimore, USA in 2013. She also had in 2018, Nigerian Healthcare Excellence Award, Nursing and Midwifery Excellence Award of the Year, and Leadership Award for Advancing Nursing in Africa by Lead Nurse Africa International Foundation in 2018. She has won many research grants, including the Visiting Researchers Grant, Medical Research Council of South Africa in 2002, Council for the Development of Social Science Research in Africa, Codestria, Small Grant for Thesis Writing Award in 2004, HIV Research Trust Grant, UK 2004, Major Evaluation Funding for Development of Monitoring and Evaluation course in the Bachelor of Nursing Science program in 2013. She has served in various capacities at all levels in the university with many governmental, non-governmental organizations and communities outside the university. She has authored and co-authored 2 books and over 75 articles published in reputable local and international journals. She's a member of Teachers, She's a teacher of teachers, a seasoned scholar, mentor, mother, and grandmother. She's married and blessed with 2 children, Oluwasegun and Toluwalope. We'll listen to Professor Omolola Oladunni Irinoye as she presents the 355th inaugural lecture of this university titled Sexual and Reproductive Health Matters, Subjectivity and Objectivity in the Community, Public Health Nurse Practitioners Experience. Over to you, Professor Irinoye.
Mr. Vice Chancellor, sir, Principal Officers of the University, members of Council, members of Senate, Provosts, Deans, Directors, Heads of Departments, distinguished colleagues, invited guests, from within the university and outside, gentlemen of the press, ladies and gentlemen, I stand before you today with a deep sense of gratitude to the Almighty God, who deserves all the glory and adoration for being my sufficiency to present the 355th inaugural lecture of the Obafemi Awolowo University. This is the third inaugural lecture from Department of Nursing Science, and I titled it Sexual and Reproductive Health Matters, Subjectivity and Objectivity in the Community Public Health Nurse Practitioner's Experience. I acknowledge the grace of God, the gift of very supportive families, an intellectually challenging academic environment, great teachers, mentors, and friends who contributed in no less measures to how I got here. I was the third of 4 siblings from Mr. Samuel Bolarinde from Ile Okun Okeru and Mrs. Elizabeth Anaoni from Ile Alemore family, Odowo, both from Imesile. I fondly remember both of them for guiding us into appreciating the value of education, despite the fact that my father was never able to finish schooling because she lost his father. I dedicate this inaugural lecture to my brother, late Mr. Victor Olubumi, who made sure that I went to Imesile High School, even in the face of all uncertainties, and to my cousin, late Miss Lydia Iyabo Bifani, who mentored some of us as teenagers and divinely directed me to go to School of Nursing, UCH, even when I never thought along that line. Mr. Vice Chancellor, sir, my big challenge today is to speak to my teaching career of 30 years and my research and contribution to 2 books and over 75 journal articles. I'm also expected to speak to all my community services at the university, community, state, national, international, and professional levels in less than 1 hour. It is a challenge, but I serve an able God. And so in the beginning, so God created man in his own image. In the image of God created he him, male and female created he them. And God blessed them, and God said unto them, be fruitful and multiply, and replenish the earth, and subdue it. And so, the objectivity and subjectivity in sexual reproductive health began. Sex differentiation and physiological assignments of who gave birth, sociological roles of who carried what burdens, the pleasure and pains of being females and being males in sexual context. Omolola, the educationist and teacher. I teach nursing, other health sciences, education and social sciences, and I've taught in 5 universities in Nigeria and 1 university outside Nigeria. I've facilitated the establishment and development of undergraduate and postgraduate programs in nursing in and outside Nigeria. I've stopped counting academic and non-academic lectures. I've only focused on helping people to learn. I supervise between 15 to 20 undergraduate students per year in OAU, and I've supervised 20 master's students, 4 doctoral students at the Obafemi Awolowo University, and a few outside OAU and Nigeria. I'm currently supervising 3 masters and 2 doctoral students in OAU. I teach within multidisciplinary context and promote interprofessional education orientation of health professionals. Omolola as the scholar and researcher. Mr. Vice Chancellor, sir, my research covers 5 major areas: sexuality, sexual and reproductive health issues, focusing on adolescents, women, and the family; sexual and reproductive health in the context of sexually transmitted infections, HIV and AIDS; maternal and child health, issues of access and standard of care; family nursing, family health promotion and care, and the context of family violence. I also research technology, deployment in nursing education and practice. For this presentation, I'm going to be reporting my research studies on 4 main areas: sexuality, sexual and reproductive health issues focusing on adolescents and the family; sexual and reproductive health in the context of sexually transmitted infections; health promotion and health status of family members and the university population. I'm also going to be speaking to context of family violence and health professionals' preparedness for care. I'm going to give my stewardship as community public health practitioner, that programs and also contextualized services, and I'm working on 3 models of health outreach programs to promote access to care for vulnerable populations. I'll give a short reflection of my activities at various levels. Considering sexuality and sexual reproductive health issues focusing on adolescents, I'm going to speak mainly to adolescent sexuality, looking at their knowledge, skills, practice, risk behaviors, and available support. I'm also going to speak to sexually transmitted infections, their knowledge, their preventive behavior, and available support. I'm going to be speaking to teenage pregnancy, causes, concerns, and suggestions, as well as prevention from the perspective of adolescents and parents. Our findings, looking at adolescents, their knowledge of sexuality. Knowledge and skills for sexuality management with adolescents, our findings showed inconsistent and low access to information, education, and communication from relevant persons. And relevant persons to adolescents included parents, teachers, and healthcare providers. Inadequate support services for optimal sexual and reproductive health of adolescents at the family, at the school, and at the community level. Looking at sexual risk taken by adolescents, our findings show that 2 problems from literature show that adolescents accounted for half of HIV infection, and increasing prevalence of teenage pregnancy was also documented. Our findings show that majority engage in high-risk behavior, engage less in preventive behavior, and poorly perceived their risk status. Findings looking at parents and adolescents' views about teenage pregnancy. For adolescents, causes and risk factors of teenage pregnancy include lack of parental guidance, lack of appropriate sex education, lack of material resources to meet the needs of adolescents because of poor socioeconomic status of parents, and influence of peer groups. For parents, their perception of causes included waywardness of teenagers and lack of discipline among teenagers. Again, looking at concerns by parents and by adolescents. Adolescents showed concern in the area of disruption in education, limits placed on attaining future career prospects, risk of stigma to face considered as second-hand good after giving birth, and inability to get good suitors. These concerns inform strong decision by adolescents to procure abortion. However, for parents, concerns of fathers relate to immediate economic challenge of providing resources to meet the needs of pregnant mother. And for mothers, their concerns included shame the teenage mother will bring, the health of teenage mother, and the negative reactions, including rejection and condemnation, and possible expulsion of both the mother and pregnant daughter from home by the father. One concern by an adolescent, a male adolescent, has to do with mothers who promote their male adolescents to engage in sex to ascertain their virility. Looking at prescriptions for prevention, adolescents have the following: access to information about sex and sexuality given at appropriate time, in appropriate ways, regular counseling and not harassment and threats will help. Female adolescents expected a change from putting all the blames on girls. According to a 16-year-old girl, you see, many times one cannot discuss what those boys do to one, because if you tell your peers, they either make jest of you that you are odoko, or some will tell you that you are not sociable. And if you get home and say anything, they may start abusing you that you have started having sexual intercourse. For parents, their prescriptions had to do with parents to relate more closely with their adolescents, and for fathers in particular, parents are expected to regularly warn female adolescents to avoid bad company and avoiding getting impregnated. And such warning are expected to be the responsibility of the mother. For mothers, their prescription was that fathers should get involved in general socialization of children, and they should instruct girls to stay away from boys who will spoil their lives. Our conclusions from our findings: most parents do not have adequate knowledge and skills to provide support on sex and sexuality education for their adolescent kids. Most parents still use the fear-instilling method, non-specific instructions and warning, rather than engaging in empowering communication and training of adolescents. Many adolescents do not have access to standardized sexuality education. They lack knowledge and skills, but they aspire to have desirable capacity building for effective sexuality management. Adolescents and parents' perception of causes, concerns, and actions for prevention of teenage pregnancy were incongruent, and parents are responding to crises of growing among adolescents in wrong ways. Again, we observe gross inadequate resources at all levels of socialization for optimal management of sexual and reproductive health of adolescents at the family level, at the school level, at the community level. Parents, adolescents, and health professionals, as well as other socialization agencies, are not communicating effectively and efficiently to help adolescents prevent and manage crises of growing up into active sexual beings. Health professionals are not currently providing desirable sexuality education, guidance, and counseling and support as most desirable, especially at the family, at the school, and at the community levels. Sexual health matters. What do parents need? Parents need help in the following areas. Many parents still rely on the traditional method of giving vague information, threats, and warning, and they are unable to offer their teens the needed education and support to successfully navigate the teenage and young adulthood sexual and reproductive life. Parents need help to acquire knowledge, skills, attitude, and alternative parenting methods quite different from what they experienced. Community public health nurse practitioners are needed more to function at the family and community levels, less of practice in offices and facility settings. Adolescents also need help. Many adolescents still depend on pieces of uncoordinated information from parents, peers, and social media. Adolescents experience contradictions and confusion resulting from how family members manage challenging crises. All adolescents need to be supported to learn non-abusive, non-coercive communication, respect for persons, positive conflict management strategies, and non-violating relationships from the family setting. And to give more details, adolescents need education, they need positive communication, they need skills building, they need relationship building from family first, then with others. They need material support, they need guidance, they need counseling, they need psychosocial support. And for those who get pregnant along the way, it is important that we show empathy and we help them get back to school or vocational training. Mr. Vice Chancellor, sir, of all the significant orders to adolescents, parents, peers, siblings, teachers, and health professionals are required to empower all who may all be operating in positions of ignorance. The best places for health professionals to intervene, those are at the family and community levels. The school is an important and strategic location to empower adolescents. Our intervention, following our research studies among adolescents, was the development of a training package that we have been using to train adolescents as peer educators and to train teachers and other older youths as youth mentors at the community level. We have used this training manual in many schools as presented here. Some of these schools are in Ile-Ife and around, and some are in Obokun local government. Sexuality, sexual and reproductive health learning and communication at the family and community level among cohorts of Yoruba people. We are focusing on Yoruba people because sexuality behavior, sexuality management has cultural undertones, and there are variations in different cultures. And you will see from our discourse, communication of sexuality is intergenerational, from the very old to the middle adults and to the young adolescents. I investigated how the Yoruba people communicate sexuality, sexual and reproductive health issues as the individual matures into adulthood. I also explored how the Yoruba ways of life can be used to explain what we see as sexual and reproductive health issues, responses, and management. I gained some insight into the context of learning and living sexuality and how this translates to normative sexual relationship, especially looking at consensus, coercive, or forced sexual intercourse. Now, our findings show that little differences among many sub-ethnic Yoruba groups exist. Across board, they use language, proverbs, songs, and artifacts in an unorganized way to communicate contents of sexuality, sexual and reproductive health matters. Individuals learn along the line without concrete and organized education by anyone so designated to do that. Sexual relationships were built around the conception and social constructions of active masculinity and passive femininity. Sexuality and sexual relationship evolved as a transitional phenomenon. Individuals are expected to learn instinctively as they attain sexual biological maturity and to learn informally from others. No organized and formal education at any point in life. From our findings, some of the information that we have has to do with how do Yoruba people regulate sexual behavior and how do they negotiate or discuss sexuality on a daily basis. From what they have shown up, we have samples of Mogun and sample of Betu that we got in the field as some of the things that Yoruba people use to control sexual behavior. However, in day-to-day activities, you will see two things that you are perhaps conversant with in the market. There's a big bag that we use to carry things in the market that is called patanla. And there's the small ones that market women use to pack salt and sugar that is called yodi. Among the Yoruba people, some of the languages on a daily basis, I'll just give one or two. Ejekolobo oro, eni adoni kako, which implies mind your business. Isiro loko dido, ewo ni kado ni lekan, kafuni ni toro. This also talks about economic implications of sexual relationship. O feju toto bi oju adofuro, which implies that even in the Yoruba context, homosexuality had been identified, documented, even before we get to know about it with HIV and AIDS. Which implies that could penis be a tool of transmitting heredity? These are day-to-day communications in Yoruba interactive activities with kids, with young people, without other means of also communicating correct information. Our findings that inform sexual behavior, our studies showed a changing conception of femininity, especially among young people that are no longer passive. And this also informed their changing sexual behavior. Relationships are moderated by age, economic status, and marriage with women in subordinate position to men, either in social or sexual relationships. Behavior of men and women were dictated by social role assignment of leadership through economic provision for family, and control of sexual act by the man within a contractual relationship of older men with younger women, with the primary motive of procreation in traditional orientation. In this orientation, it's going to be very difficult for the woman to negotiate sex. How do Yoruba people perceive and how do they communicate sexual intercourse at the community level? Sexual intercourse is seen as a compulsory act for both men and women, especially as it resulted in procreation, though the initiation and control were part of the social responsibility of the man. It is socially approved within marriage, but premarital and extramarital relationships were tolerated more for men, but frowned at for women. Sexual intercourse are used for many purposes, and these include using sexual intercourse as a proof of self, as ego booster, used to heighten or improve status, used for economic gains, used to demonstrate love, used for enjoyment, and as a tool of punishment of women by some men. And these are the languages that young people also learn, they grow up with, that they then begin to live on a daily basis that then become sources of problem for us when we're talking about what we need to do to achieve positive sexual health. Knowledge acquisition about sexual relationships and sexual intercourse tended to be inadequate throughout the lifespan. Despite a representation and communication of sexuality and sex in everyday life, there was never a time when individuals, even after marriage, have access to organized, standardized, correct information about sexual intercourse. Gross assumption of what sexual partners know about sexual intercourse was dominant in the population. Our observation showed that over 50% of male and female respondents expressed lack of knowledge in all the 13 identified topic areas for positive sexual health. Sexual behaviors of individuals were regulated through instructions, warnings, and punishment that could range from verbal warning to flogging and death through the use of some traditional medicine, such as mogun and betu-betu, as earlier shown. Findings with regards to consensus coerced forced sex among men and women. Sexual coercion and violence were generally condemned in the culture from qualitative data. However, sexual coercion and violence was common. Experiences of consensual coerced or forced sexual intercourse at forced sexual experience at the time of our study were similar for both males and females. At forced sexual intercourse, for majority of respondents was by consensus, while about 35% had such through coercion or by force. Experiences of sexual intercourse showed that 48% had such by consensus, and 33% had sexual intercourse by coercion or by force. More respondents in the married category reported experiences of sexual intercourse by coercion and by force. About 31% of respondents reported sexual intercourse-related ill health and problems. Coerced and forced sexual intercourse was reported as common by 54% of the respondents. More married respondents reported forced sexual intercourse as common. Many men reported personal experiences of coerced and forced sex. Our conclusions and action thereafter. My teaching, counseling, and support practices for sexual and reproductive health for men and women changed. I no longer assume that men and women know or do. I no longer assume what they know or what they do. Both men and women need help to have fulfilling sexual relationships and sexual health. Many men are also experiencing sexual coercion and violence, especially with older women. Most men had not been able to share personal experiences and the psychosocial burden they carried. Resources are needed to develop standardized training and service provision protocol to target members of the family and socialization agencies at the community level. Sexual health matters. Mr. Vice Chancellor, sir, we must structure out and improve upon communication of facts and building capacities for sexuality, sexual and reproductive health to meet different needs of different people at different stages of life. It is important to build capacity for sexual and reproductive health, and this must start very early in childhood and must be continuous and must be throughout the life cycle. Importantly, health professionals who are to handle sexual and reproductive health are needed across the lifespan, and they need to be more than they need to have more than generalist education for them to be able to do what they have to do. Now, we need to look at meeting care and counseling needs of clients, especially with sexually transmitted infections, HIV, and other diseases that are now emerging that have sexual intercourse challenges. In our study of traditional medical practitioners, we had to study traditional medical practitioners because we realized that many of our clients consult both orthodox and traditional medical practitioners, especially with diseases that they could not get cure to. We investigated the awareness, diagnostic methods and treatment, and perceived effectiveness of treatment of STDs among traditional medical practitioners. Majority of respondents claim information about HIV that they got from their ancestors. All had experiences of treating patients with STI, symptomatically diagnosed and managed the diseases, and over 40% claim they had treated patients with HIV before the study. Preventive behaviors promoted among the patients included abstinence, chastity, use of condom, performance of some rituals, use of herbal concoctions. All respondents were willing to have traditional training, were willing to have additional training, and as high as 70.6% were willing to pay for such training to learn more about HIV. This was a lesson for us. Working at the community level, we may always have to work with traditional practitioners, and their willingness to want to be trained is a motivation that we need to always consider. Now, we also look at care and support among nurses, looking at their knowledge, their attitude, their concerns, especially in the context of caring for people living with HIV and any other diseases that are transmissible. We observe high level of anxiety among healthcare providers in the early stage of HIV, and that they showed high level of anxiety. There was high tendency for nurses to avoid patients diagnosed to be living with HIV, and there were loose comments about people caring for people living with HIV. We investigated their knowledge, their attitude, and concerns towards caring for this kind of clients in the teaching hospital. Majority of the respondents had low knowledge, they had fear of contracting the disease, and expressed concern about their low ability to provide empathetic care to the patients. Again, we look at their counseling skills and practices as they are expected to provide counseling for young people with STI and HIV/AIDS. We realize that people need counseling support to manage their sexuality, to reduce the burden and fear of STI, and importantly, to manage sexual dysfunctions. We assess nurses' knowledge of basic counseling strategies and their ability to apply such to provide focused counseling for STI among young people. Our findings show that high percentage of nurses were conservative, unable to communicate sexuality and sex-related matters, even among colleagues, and might not be able to professionally manage clients with sexuality and sex-related problems efficiently. The assumption that males fare better in communication of sex-related matter was relative, as male respondents expressed ease of communication better with peers, but not among colleagues, spouse, female friends, their children, clients, and among their parents. To bridge this gap, we incorporated health counseling into community health nursing content of our BNSC degree program. We also conducted a series of training in counseling for health professionals during the period. Family health promotion and care. Family health is a major focus of education, research, practice for the community public health nurse practitioner. Health and health care of every individual revolves around the family as the unit of care. Health and ill health happen at the household level. And the households are the best places where community public health nurses should help families take responsibilities for their health. It's also the best place to attend to physical complaints as well as the psychosocial context of health and ill health. Our studies in these areas cover the following listed items: curricular review for family health nursing contents in the undergraduate and postgraduate nursing program, health promoting behaviors and health status of family members with focus on prevention of non-communicable diseases, health promoting behaviors among university workers. We were particularly interested in looking at health promoting behaviors of university workers. And we also target development of a software app to promote health promoting behavior among university workers. We examine health status of families in the context of the family structure, looking at single and two-parent families and family functioning. We also look at health status of families and their children, considering their structure and some health indicators. Our findings. Findings from the curricula that we reviewed was used as evidence to review our curricula, especially the postgraduate program. Findings from the health promoting behaviors and health status of women showed that none of the sub-scales of health promoting lifestyles were practiced adequately to a level that can drive the control of non-communicable diseases among the study population. There was statistically significant relationship between the BMI and hypertension, supporting the need for health-promoting lifestyle intervention programs. Our conclusion was that rural women had inadequate information, low guidance, and were not consciously engaging in health-promoting lifestyle, but were willing to adopt appropriate health behavior if they had adequate information. Looking at health-promoting behaviors among university workers. Our findings show that good physical activity lifestyle behavior and good health responsibility lifestyle behavior were statistically significant predictors of normal body mass index. Also, good health promoting lifestyle profile was statistically significant predictor of normal waist-hip ratio. Our conclusion was that good health promoting lifestyle behavior, especially in the areas of health responsibility, physical activity, and stress management behavior, are determinants of overweight and obesity, which are major risk factors for development of cardiovascular diseases, type 2 diabetes, and some forms of cancer. To reduce the risk of developing uncommunicable diseases, the need to develop intervention to improve university employees' health-promoting lifestyle became obvious. And what we then did was to work on development of a software app to drive health-promoting behavior among university workers. The study to develop this software focused on developing and pilot testing a software application that can be used to advance health-promoting behavior among university staff. An operational research approach was adopted to develop the model. The result of the pilot testing of the model showed that the model enhanced health-promoting lifestyle behaviors and improved the health status of staff. We concluded that nurses, especially community public health nursing practitioners, with sound competence in nursing informatics, could provide innovative interventions to drive and enhance health-promoting lifestyle behavior and improve health status of workers, not only university workers, but all workers, and other population groups within the family through effective use of ICT. Looking at health status of families in the context of family structures and family functioning, we look at two-parent families and we look at one-parent families. And our findings show that two-parent families had higher family functioning than one-parent families. Using the BMI classification as measures of assessment, one-parent mothers are healthier than two-parent mothers. For men, less than half of the fathers from both one-parent family and two-parent families had normal BMI, which means that for both one-parent fathers and two-parent fathers, they were not living healthily. Using the blood pressure classification, findings show that less than half of mothers from one-parent family and two-parent family had normal blood pressure. Among fathers also, less than 50% of one-parent and two-parent family also had normal blood pressure. Briefly, this is a graphic representation looking at the basal metabolic index of mothers for one-parent families and two-parent families, and the same for fathers, looking at one-parent family and two-parent families. Looking at family structure and the health status of parents and their children, findings show that one-parent fathers had the highest score and thus was the most healthy, followed by two-parent fathers and one-parent mothers, while the two-parent mothers had the least health status. Health status of children from one-parent and two-parent families on each of the 9 principal health status domains revealed that mean scores of the children in both families in all the domains were very similar. However, children of one-parent family had slightly lower scores in self-esteem and in role limitation because of emotional problems. We recognize the need for additional attention and psychological support for children from one-parent families by community public health nurses until when we have more family health nurses, as we concede to observations of stigma and stress that such children and their parents tend to face in our society. Now, we want to present the context of family violence and preparedness of healthcare providers to care for people experiencing family violence. Our study of senior and secondary school adolescents in Ile-Ife on the perceived causes of family violence showed that 60% of adolescents identified 11 of the 12 listed perceived causes of family violence, with adultery as the most common perceived cause in the family. Another study sought to reconcile conception, experiences, and perceived effectiveness of management strategies adopted for intimate partner violence by ever-married women and men at the community level. Both men and women have their shares of experiences of violence that should not be overlooked to stem intergenerational transmission of intimate partner violence. Figures 10 and 11 give succinct summaries of some of our findings, and we observe that men seldom expressed their experiences of intimate partner violence. Both men and women poorly sought counseling, but the situation was worse for men. There is a conception of violence among ever-married men and women put in graphical representation. And this briefly shows us a summary of whether men and women who ever experienced intimate partner violence sought for counseling. And we observe that men seldom seek for counseling. Few women that sought for counseling use the church as a point of receiving counseling. Context of family violence. We did another qualitative exploration of intergenerational views of violence, looking at adolescents, young adults, and older adults. And this was conducted to give understanding to changing conceptions and interpretations, as well as to get prescriptions from these people on what needs to be done to limit family violence. Findings reinstated multiplicity of definitions with no single word for either abuse or violence. Verbal assaults were common among parents to children, among husbands to wives, and very common among older siblings to younger siblings. Physical beating of children by parents were reported as very common by all groups, and while physical assault was reported by all groups. Neglect and abandonment of children and wives were reported by all groups and noted to increase with economic hardships. Neglect and abandonment of men reported by male older adults and middle-aged male group, but not by older, middle-aged, and young females and young males. Neglect and abandonment of the elderly people was noted to have increased by all groups due to increasing economic hardship. What are the management strategies in Yoruba cultural context? Our findings show that management strategies involve the extended family and social support system, following the established protocols and adopting what was presented as a win-win approach of ensuring all parties involved in violence are penalized. All the groups indicated that all categories of healthcare workers, social workers, law enforcement agents, the judiciary, and other traditional and social groups did not play significant roles in the prevention and control of family violence. The young female adults indicated that, if anything, the police make matters worse because they are not women-friendly. Male older adults emphasized that the police were more of threat than help in managing family violence because they also perpetuate violence in their relationships. Customary court was considered better to be used for intervention in managing family violence. They always adopted Yoruba method of crisis management of a win-win resolution of crisis, and magistrates and high courts were said to adopt win-lose approaches, which was considered unwise in family matters. The win-win approach was more acceptable to participants, as it gave the opportunity for reflection and self-restraint on the individuals involved in prevention and occurrence. The social welfare office and healthcare workers were recommended as people to make the issue of family violence visible and actionable. Nurses need to be empowered to identify individuals and families at risk, to pick cues of ongoing violence occurring in the family, to provide care and coordinate innovative interventions. Our families, what do we expect our families to reflect? For us to prevent violence, for us to help people manage their sexuality, we need families that are friendly. We need to avoid families that are destructive. Healthcare providers' preparedness to detect and manage family violence. Our first investigation investigated the extent to which health professionals could recognize some indices of violence against women. Our findings show that 30% of the respondents in a teaching hospital might not appropriately detect violence against women. Another investigation among nurses and doctors assessed preparedness for management of prevention of violence against women. Majority had negative attitude to wife battery. However, majority indicated that wife battery was caused by the victim's psychological problem. Majority also expressed that abused women cause themselves to be hit by provoking the husbands. And majority also expressed that husbands who batter their wives deserve sympathy since they are emotionally disturbed. And 29% indicated that doctors should only treat injuries and not query or advise a battered woman. Doctors and nurses in the tertiary institution of study were generally informed about what constituted violence against women. The knowledge of health professionals about violence against women was better than from previous study, but their attitude was poor for what might be expected of health professionals. The lessons that we learned from our study had to do with the urgent need to train health professionals to improve on their attitude to management of women perceived to be experiencing violence against women. There is also a need to investigate the prevalence of family violence and its various forms even among health professionals. To respond to this, I worked with one of my PhD students to develop and test a training package to build capacity of nurse midwives for screening and management of IPV in healthcare facilities in Ekiti State. My community public health nurse practitioners' role in provision of vulnerable populations, provision of service to vulnerable populations through medical outreaches. I've tried to work within 3 models of care. The first model brings about getting institutional and community to work together as partners to support health care to very vulnerable populations. And in doing this, a team of OAU healthcare providers work with a community-based organization, the Ijesha North Consultative Association, to provide health care to vulnerable populations over time on several occasions. This organization is still open to continue with this model of supporting health care to vulnerable populations at the community level. Another model that I've worked with is to work within an NGO, mobilized health professionals and volunteer-driven model that had also become a source of health care provision for vulnerable populations in very rural communities. The third model that I call the Mesile model as international and local collaboration for a community-oriented services to support vulnerable population in the community. And this has transited to a community-initiated healthcare support partnership model, where members of the community continuously contribute funds to support healthcare to every vulnerable members of that community. My stewardship as professional leader and as administrator, I've served in various capacities at the departmental level, at the faculty level, and at the college level. And I've also served in the university beyond the regular statutory memberships of panels, committees, and boards. And my last appointment with serving in the university was when I was All Mistress of Mozambique between 2011 and 2016. I also engage in other intellectual engagements. And to support my intellectual growth, I've attended over 97 update and capacity building sessions of conferences, workshops, and seminars between 1991 and 2021. I also served as a member of the editorial board and reviewer to some journals, as listed. Within programs and service support in HIV care in OAU and OHAC, I served within the African AIDS Research Network and the Starfish Project between 1997 and 2013. And also, in the Starfish Project, served as secretary between 2002 and 2008. In the Japan International Cooperation Project, where resources were provided to support healthcare for people living with HIV, for preparation of herbal medications, I also served as secretary between 2008 and 2013. I served in the commencement of the Youth Friendly Center between 2005 and 2018. And the Youth Friendly Center is working very well in the university. Looking at my stewardship as a professional programmer at the state, national, and international level, I've served in HIV/AIDS healthcare advancement in Osun, Ondo, and Ekiti states. And at the national level, working with the Federal Ministry of Women's Affairs, I led the establishment of the Vulnerable Children's Unit. I contributed to policy documents, training to drive care and support of vulnerable children from 2004 to date. I also support national, state, and local government organizations providing care and support for vulnerable children. I've worked with many United Nations agencies to serve in terms of program conception, service planning, and service monitoring. I've received some honors, distinctions, fellowship grants, and other awards. And I'm just not going to bore you with listing, but you will see as they have been listed on the 2 slides. Mr. Vice Chancellor, sir, my conclusion, my reflections. The journey into the academia could be exciting, could be challenging, could be stimulating and demanding, but could also be fulfilling with availability of resources to function. I've experienced all this as an educationist and teacher, as a scholar and researcher, and as a practitioner. As an educationist that is consistently looking at building people for a better future, I perhaps could have done better with more resources at my disposal. In many countries of the world, nurses with higher education facilitate quality and better access to health promotion, disease prevention, rehabilitation, family-focused care through the Advanced Nurse Practice Program, and utilizing the clinical nurse specialists to improve access to quality care in various subspecialties in hospital care. There is need for higher level of understanding among health professionals about the changing trend in expanded roles and professional boundary realignment to enhance better access to health care for the benefit of the clients in the face of technology support available to drive health care. From another perspective, emphasis has shifted to more health promotion, disease prevention, supportive care that empowers and enables patients take more responsibility for health and engage more in self-care at the family and community level. Our goal should be to reduce hospitalization, to reduce hospital visits, and more family and community-oriented care. Empowering our people to take responsibility for their health, reducing the burden of preventable diseases across age categories and lifespan also require that we reduce politics in healthcare, invest into people's empowerment for health from early life. Essentially, countries who value their children ensure that every child is given a head start and equal opportunity for health through well-structured school programs, and services and support are provided that enables the child to learn and master sexuality and sexual health with efficient use of trained school nurses who work with schools and families. Sexual health do matter. Sexual health needs and support differ at different stages of life. A fulfilling sexual life requires different and purposeful capacity building that takes its root from the family. Our research findings have shown huge gaps between needs, services, and supports that are available to all family members. And government at all levels need to leverage on the existing huge amount of data available in our universities that must be used as evidence to inform their decisions and actions in healthcare to support family and community health. Closing reflections and future plans. Most of my work that I've spoken about in this inaugural lecture are yet unfinished businesses. We have acquired extensive knowledge in several areas of our work that we are already using to bring about desirable changes to impact nursing education, practice, access to health and health care of our people at all levels of care. Importantly, we must shift focus to intervention studies and advanced implementation science that will improve access and quality of health care to our people at the family and community level. Mr. Vice Chancellor, sir, as I end this inaugural lecture, I want to first acknowledge God Almighty, who blessed me with great families, best of friends, extraordinary mentors, and encouraging colleagues. My family of birth, parents, siblings, and extended family provided me with nurturing and loving psychosocial environment that enabled me blossom and give me self-confidence through thick and thin. I'm grateful to my family of marriage and my husband, Dr. Adedayo Ishola Irinoye, through whom I received God's best gifts of 2 superordinary children, who God has also multiplied for me. My children, Engineer Oluwasegun and Mrs. Oluwakemi Irinoye, Dr. Ebenezer and Dr. Toluwalope Oladogba, and my grandchildren that give me joy and remind me of God's extraordinary and ever-reassuring love every day. I'm grateful for all you do. I could not have chosen the best of in-laws on my own, but for God who blessed me with the Oladogbas and their Adisa families. I acknowledge extraordinary mentors and support during difficult times. My superlative teacher and mother, Dr. Adebimpe Okunade, Professor Femi Soyinka, who walked me through the tenets of academics, how to be an intellectual and a thoroughbred practitioner with compassion. Professor Wale Akinshola, who taught me how to always check on younger colleagues for ideas. Professor Anthony Elujoba, who taught me humility, even with the most lowly. My PhD supervisor, late Professor Irinoye, who taught me how to think out of the box in every situation. I acknowledge Professor Bode Asubiojo, who showed me how to be a loyal ally in a situation of conviction, even in the face of divergence. I thank all my friends who always wish me well and my few extraordinary friends who always believe in me and continue to support me unconditionally. I thank Professor Oluyinka Adejumo, who always responds to my extraordinary probing about Yoruba people and keep working with me to probe more into the context of sexuality and how we can make health accessible to our people. I acknowledge my colleagues in and outside OAU and Nigeria, some of whom are here, and who continue to inspire and tolerate my brainwave and pressure as we strive for excellence in all we do. I acknowledge all my students, mentees, and co-investigators who may have found me too challenging at some times, but tolerated my discontentment with anything less than the best at all times. I am grateful to the Owaoye of Imesile, Oba Enoch Akinyemi Oyoyo too, the elders in the Imesile community, especially Sir J.F. Amilusi, who encouraged my active involvement in community engagement in the Imesile and in the Jeshanod Consultative Forum, the former president of IPA, Engineer Benjamin Olamijulo, and all the sons and daughters of the town. And I want to acknowledge the president, the current president of IPA, who is here with the wife. Thank you for honoring me. God will honor you. I'm grateful to all the Imesile sons and daughters for encouraging me to ever soar like an eagle, as I also bring my professional experiences to bear, working with the community to make healthcare accessible to the vulnerable populations. To my spiritual guide and support, Pastor Ola Olurole and Pastor Dele Akin Suroju, I'm grateful for the reassurances, prayers of faith, and your counsel that continue to serve as divine upliftment in very difficult times. To many individuals who have contributed to the success of this inaugural lecture, and the team that organized everything under the leadership of Professor Babajide Afolabi, I am grateful beyond measures. And I pray for God unending grace in all your life endeavors. To this great university and the management, who over the years has given me the platform to excel in my chosen career. Mr. Vice Chancellor, sir, I am grateful. So then, it is not of him that willeth, nor of him that runneth, but of God that showeth mercy. To God, the immortal, the invisible, the one that continues to show me mercy, who has kept me and taken me through it all, I am eternally grateful. Thank you, and God bless you.